Hello, Dr. Dilip here. I'm a nephrologist and Group Medical Director of Anion Hospitals, welcoming one and all for this teaching webinar. Today we have Dr. T.S. Srinath Kumar, who's a senior consultant who's not new to teaching here because we already heard him speak about X-ray a few weeks back, X-ray chest. The senior consultant and head and group coordinator for Department of Emergency Medicine is NH, also treasurer of International Federation of Emergency Medicine. He is a special advisory board member for DNB Emergency Medicine and also a national academic coordinator for ANBAI. Today we have a very important topic of ABG analysis and interpretation. As you all know, this COVID season, it takes more importance now with so much of hypoxia going around. So it's not only useful for respiratory medicine, as you all know, for a lot of metabolic events like renal failure, liver failure, cardiac failure, poisoning, etc. is very, very important for us to know about blood gas analysis. You must know the indication for doing, the way of doing, the way to transport it to the lab, and then interpretation of results as after we get the reports. I won't take much time. Over to Dr. Srinath for your teaching.
Thank you very much for the kind introduction, sir. Can you hear me now?
Yeah.
Yeah, okay. I think the screen is also visible clearly.
Yes,
sir. Yes, sir.
Yeah, visible.
Okay, okay. So ABG is very important in the applied basic sciences classes because whether we are any kind of a physician, as a doctor, we all have to know what is the ABG analysis and interpretation. That is why we choose this as the topic for the ABG for the basic sciences classes. And this figure, what you're going to see will be very important in the next slides, and you will understand why it is very, very important. And so I work with Narayana Hrudayalaya, which has one of the largest cardiac center in the emergency department. Now, with this pandemic season, we all know what is life. Life is becoming very difficult day by day with so many cases around us, and we are also healthcare workers are also into it, and many of us are also being exposed. But pertaining to ABG, it's like this: life is a struggle, not a sin, not against the money power. It's all against one ion, which is hydrogen, and which is all dependent on our body, and it makes us revolve around it. It's as per H.L. Mencken. So what is ABG? ABG is arterial blood gas, and we do it day in and day out in anywhere. And with this pandemic, Dr. Dilip has already said, it's very, very important because most of the patients come with COVID. We have to first check out what is gas analysis is, and then only we plan for the treatment, and also whether this patient is asymptomatic or symptomatic. And where all you can draw the blood for the analysis of the ABG is usually in the radial or the femoral. Very rarely we use other places if at all we don't get it. And it is also an invasive procedure, we all know it. But only thing is caution is we use a lot of anticoagulants nowadays. You have to be very careful with it. And then it is becoming very important for diagnosing and managing every patient who comes into the hospital nowadays. And depending upon you are going to ventilation or even the acid-base balance, what we have to do. So what are you going to learn today is about a brief introduction about the topic, and then what are the basics about the acid and the base. I'll not be taking you totally into the acid and the base. So brief about acid, regulation of the hydrogen ions, and what is the respiratory control and control of the acid-base disorders. And finally, we'll see into how we interpret the acid-base disorders. So we use a lot of fluids in the hospitals. So use of say normal saline, Ringer lactate, or blood, or anything, whatever you give it, there will be a change in the pH. So that is the reason why we have to know about the ABG. And to understand the physiological processes involved in the acid-base disorders, that's what you're going to see today, ABG. and also to take in from a stepwise manner about the patient evaluation for the acid-base disorders. And lastly, you also look into the gaps, anion gap. So what is anion gap? What is delta anion gap? What is osmolar gap? What is urinary anion gap? All these things we are going to look into in the next slides. So this is how we are going to look into each and every part of the acid base in the next few slides. So every time what anybody, any clinician says is, you should know what is the normal value. Only when you know the normal value, then only you can say about the abnormal value. So the normal pH is between 7.35 to 7.45. Anything less than 7.35, we know what it is, and anything more than 7.45, what it is. And what is the carbon dioxide levels? That is the PaCO2. That is a partial accepted carbon dioxide. That is the accepted levels. That is between 35 to 45 millimeters. That is what has been said. And the oxygen levels is between 97 millimeters of mercury on room air. That is 21% of oxygen. And then when the patient is on ventilator, you would see at least 60 to 90 millimeters of mercury. And the bicarbs, which is normally present, is between 22 to 26. That is what is a normal. Now, what will happen with every acid-base illnesses? Are you going to treat the acid-base illness? I don't think so. Anybody will be treating about the acid-base illness, but we will be looking into how to monitor them and what is causing the real problem with the acid-base illness and how you are going to treat the primary cause. You should not think about treating the acid-base as such. You have to treat only the primary cause. That is what is important looking into the acid-base. When you're looking into some of the examples, you'll be looking in and telling, okay, this is how I want to see and I want to do it. But whenever there is a disturbance, what happens in our body is, one is cerebral edema can happen. It can involve any part of the body. So cerebral edema can happen, patient can have seizures, its effect on the heart based on carbon dioxide levels or hydrogen ion levels. It can affect the myocardial contractility. And we all know whenever there is an acid-base imbalance, the potassium levels will also fluctuate. So when potassium levels fluctuate, you'll have cardiac dysarrhythmias. And then when carbon dioxide levels are been imbalanced, what happens? The primary mechanism is in the lungs. So the carbon dioxide levels. So based on that, the pulmonary vasoconstriction happens. So to decrease all these things, the systemic vasodilation happens. So one is interlinked to other one. So you have to look into the acid base and then treat accordingly. What is the primary cause? Okay, this is what. Is it a diabetes? It is something related to COPD. It is related to diarrhea. You have to look into these things and then treat the cause. When you treat the cause, the acid base itself will get rectified and the normalization happens. So where do you see? We are looking into basically into the extracellular pH. We are not looking into the intracellular. You're taking the arterial blood, looking into the pH. So it defines the changes in the extracellular pH. That is what you look into, whether there is results of an acid or a base load, which is overwhelming the excretory capacity of the respiratory or excretory functions. So this is what you're going to look in for. Now, what is acid and what is an alkali? So acid is nothing but the hydrogen ions and alkali is nothing but because of the hydroxy ions in the water. Okay. So acid is proton donor and alkali is electron pair donor. So acid is hydrogen, alkali is H plus acceptor. So this is the basic concept which we have to understand. And to keep everything in loop, we require something called as a buffer. Only when there is a buffer, the hydrogen, carbon dioxide, and the bicarbonate, all these three things will be kept in loop. So for that, the buffers are required. That is in the simplest terms. So now looking into what are the problems with the hydrogen ion and how there is a defenses which happens for the hydrogen ions. There are three mechanisms which will control the hydrogen ions to prevent acidosis or alkalosis. The three mechanisms are: first is your acid-base buffer system, second is your respiratory system, third is your kidney renal system. So in the acid-base buffer system, it combines immediately with the acid or the base to prevent the changes. That is what is a buffer, what I've already explained to you. Now, what does the respiratory system do? The respiratory system will regulate the movement of the carbon dioxide in the ventilation. That is the alveolar ventilation. So how much ever you take the air, the carbon dioxide, what is required is retained and whatever is not required is taken out. So that regulates the hydrogen ion in the respiratory system. In the kidneys, basically the bicarbonates, and it can either excrete or retain the hydrogen to make it whether you want an acidic urine or an alkaline urine based on the adjustment of the hydrogen which is present in the extracellular pH. So what is the time response of all these defenses? You can see this. It's so important that within whatever the changes are, within few seconds to minutes, everything comes into place. That is your buffer system, your respiratory system, and the renal system. So all these three systems comes into place to defend itself, the acid and the base metabolism. So the first two defenses keep the hydrogen ion concentration within normal until the renal system either increases or decreases the take in or take off of the hydrogen ion as an acid or a base. So what are the buffers which I was speaking on? So these are the various buffers which are present in our body, which maintains in the body to maintain the pH and give you the normal pH which is required for normal functioning of the patient. So that these buffers play a very, very important role, especially you can see there the blood where the hemoglobin where it forms the ferritin or the ferritin, these things to with combining with the carbon dioxide and makes it neutralization. So phosphates, it's not very important. Bicarbonate is very, very important because it is a major metabolic acid which is present. And based on the bicarbonate levels, you can see in the further steps how it monitors and makes the pH normalization. Hemoglobin, as I mentioned, for carbon dioxide, plasma is not that important. But when you compare to the intracellular, the proteins and the phosphate, those are the important buffers apart from your urine where the phosphates and the ammonium is present. And in the bone, whenever there is prolonged acidosis, then the calcium carbonate comes into picture. So these are the physiological buffers which are present within ourselves, tend to maintain the pH of the patient. Now, as I mentioned, the respiratory system, which is the major regulator of the acid-base disorder, there are two important functions of the respiratory system. One is ventilation, second is oxygenation. So by what do you mean by ventilation? You're going to clear the carbon dioxide from the body. What is oxygenation? It is a diffusion of oxygen from the lungs into the tissues. So this is the major mechanism, as it is mentioned in my first slide, that the respiratory system mainly monitors the carbon dioxide. Now, a little bit about the alveolar ventilation, which is very important because whatever the air which we take, which is very important to monitor the carbon dioxide. So based on the requirement of the carbon dioxide, the respiratory system involves and takes as much as carbon dioxide is required, and whatever is not required, it has been thrown out. So that is how it maintains. If you see in the COPD patient or an asthma patient, the carbon dioxide levels are more than normal, but still we say that, okay, it is acceptable because that level of carbon dioxide is required for those patients. But when you see another patient like a diarrhea or somebody who's on ventilator, not a patient with a systemic inflammatory response system or a acute respiratory distress syndrome, he doesn't require that much. So every patient, it depends upon what kind of an illness he has and how much of carbon dioxide is required and not required. The PCO2 excellent index of the adequacy of the ventilation. That is what is the most important point. So you can see here, the carbon dioxide is increased via inadequate, then there is respiratory acidosis. Whenever the carbon dioxide is increased, that means that the patient is having more PaCO2 in his body. So immediately you can say that this patient has respiratory acidosis. Whenever the PaCO2 is low, then it is respiratory alkalosis. That is a basic funda which we have to understand. Now we have seen about the hydrogen ion. Now coming to the carbon dioxide levels, there are three types which has been transported. One is directly the carbon dioxide is dissolved across the cells. Second is bicarbonate. Third is carbamino compounds. So these are the three types, various mechanisms where the carbon dioxide is being transported within the blood. Now, as bicarbonate, you can see here the carbon dioxide with water will always lead into carbonic acid. Then it is released into hydrogen ion and bicarbonate. And the bicarbonate is mainly regulated in the kidneys. That's what I said you. So you can see that the first half you can see in the lungs, which maintain the carbon dioxide. In the renal system, it is a bicarbonate. So these are the two things. In between forms the hydrogen ion. So this is how it has been maintained. Now, the overall mechanism, what we have to understand about a respiratory regulation in the acid-base balances, whenever there is an increased ventilation, it eliminates carbon dioxide. That is what we usually see in case of an respiratory alkalosis. So what happens is the hydrogen ion is dipping. And whenever there is decreased ventilation, that means that if the patient is not taking proper breathing, that means that there is more accumulation of the carbon dioxide. When there is more accumulation of carbon dioxide, the hydrogen ion levels are increased. That means that patient is going in for acidosis. So this is the whole concept which we have to understand, and then how the hydrogen ion is being monitored. So this is what we have to look in for. Now, what is the effect of acid-base disorders on the ventricles, in the ventilation or the alveoli? So whenever we see that there is an acidosis, the patient's pH is reduced. So what is the normal pH? What I was telling is 7.35. So we can have, whenever I ask questions, you can chat, you can put it in the chat box so that it will be easy for me that, okay, you've understood or not. So what is the normal pH? So when do you say it is acidosis? When do you say it is acidosis? When it is less than 7.35. Okay, very good. So where most of them are answering, and so that means that it is going great. So there is increased hydrogen ion concentration and increased PaCO2. So what happens is it causes increase in the VA. And whenever there is an increased alkalosis, what do you mean by alkalosis? What type of pH you are going to see in alkalosis? What should the pH be for you to tell for alkalosis? Very good. When it is more than 7.45, you tell it is alkalosis. What happens in alkalosis with the respiratory system is there will be a decrease in the hydrogen ion and also decrease in the PaCO2 levels. So that is what is here, and the respiratory system will immediately decrease the VA and it will try to bring back to the pH to normal levels. This is how it tries to manage. The ventilatory system is trying to manage based on the carbon dioxide levels. Now we'll go into the renal regulation of the acid-base disorders. Renal regulation is the most powerful regulator of acid-base balancing. One part is your ventilation, second part is your kidneys. So both the systems are very, very important to maintain your acid base in the balance and to control the acid base balance by excreting either acidic or basic urine. That is how the kidneys will function upon. But the only thing is not like the ventilation. The lungs will adjust itself very fast and tries to bring back the pH. But here, the renal system, it usually takes some hours to days to maintain the acid and the base balance. So these are the three things, how it mechanizes of the renal regulation. One is secretion of the hydrogen ions. Second is reabsorption of filtered bicarbonate. Third is by production of the new bicarbonate levels. So these are the three important mechanisms wherein the kidneys try to regulate the acid-base balance. One is hydrogen ions. Second is either it will excrete the bicarbonate or produce the bicarbonate to maintain the normal pH. So that is what it does. Now you saw the kidney, the lungs, what it does. We'll see in the same way what the renal system does when there is acid and base disorders. Now, in acidosis, what renal system will do is there is excess of hydrogen ion in the extracellular fluid. So what it does is completely
वैसे 2 दिन से मैं केक ही केक खा रहा हूँ.
and whatever the hydrogen ion which is in excess, it will try to excrete it out in the urine. That is what the renal system will do. So in acidosis, what happens is we know that the hydrogen ions are more, so it will try to excrete in the urine. That is what it does in the renal system. So whenever there is an alkalosis, that is the opposite side. When there is an alkalosis, there is excessive bicarbonate in the extracellular fluid. That is what we are going to see. So what does the kidney do? It will try to decrease the bicarb reabsorption. So what that it means? That means that it is throwing out all the bicarb which is there in excess into the urine. That is what the renal system will do whenever there is alkalosis in the body. So this is the basic concept. If you all understand what the lungs does and what the kidneys does, then your management of the acid-base disorders will become very, very easy. So this is what I was totally mentioning about putting up in a small chart. So the renal response in acid-base disorders is, that is, you saw in an acute crisis. When it is in chronic acidosis, there is an increase in the extracellular hydrogen ions and the pH is usually reduced. That is what is acidosis means. We all know that. So what happens is it stimulates the renal glutamine metabolism. So when it stimulates the renal glutamine metabolism, the excretion of the ammonium is also increased and bicarb reabsorption is increased. So these are the two things which happens when there is chronic acidosis. The kidney tries to maintain the pH by doing this stimulation of the glutamine metabolism. And when there is chronic alkalosis, what it does is it inhibits the glutamine metabolism. So in acidosis, it stimulates. In alkalosis, it inhibits. So by doing inhibition, what does it does? It reduces the ammonium excretion and it increases the bicarb excretion. So these are the two things which we have to keep in mind, what lungs does and what the kidney does. So if you understand this simple funda, it is very, very important and you can know what it does. And what are the factors which affects the hydrogen ion secretion and bicarbonate reabsorption. So this as a whole nutshell, this is how it happens. Now, simplest way, what happens in the primary chain and what is the compensation? So we all know acidosis means less than 7.35 and alkalosis means more than 7.45. That is the simplest way to mention whether this patient is in acidemia or alkalemia. Now, these are the four things which can happen in our body. 2 is respiratory system, 2 is metabolic system. In the respiratory system, it can be either acidosis or alkalosis. In the metabolic system, it can be either acidosis or metabolic alkalosis. You can see the two things which is important in the respiratory system is carbon dioxide. In the same way in metabolic, it is bicarbonate. So the pH is low, PaCO2 is high along with the bicarbonate if it is high. So pH is low, the PaCO2 and the bicarbonate is high. Simple. You think about the problem is in the lungs and it is respiratory system which is involved. So the pH is low, the problem is in the respiratory acidosis. This is the simplest way you can think of. Now, alkalosis, pH is high. What is happening in the respiratory system? The carbon dioxide is low. Along with the carbon dioxide, the bicarbonate is also low. That means that there is respiratory alkalosis. So I think you all have understood. Respiratory acidosis, pH is low, carbon dioxide and bicarb is high. When the pH is high and the bicarb and the carbon dioxide is low, that means that respiratory alkalosis. So this is the simplest way to understand. Now coming to when the carbon dioxide is low and bicarb is also low, you can see that if it is reverse, everything is low. The pH is low, the bicarb is low, and the carbon dioxide is also low. So all three are reduced. What does it mean? It is mainly involving the metabolism, and it is implicating that metabolic acidosis is the problem. When everything is high, that means pH is more than 7.45, carbon dioxide and bicarb both are high. That means that this patient is in metabolic alkalosis. So this is the simplest thing. If you can understand, the ABG will become very, very easy to say. Of course, there are a lot of things which is not required for us. For a basic science for a class, this is what is the simplest thing what we all have to know. But a few things for the exam purpose, we have to understand few compensations which I will be mentioning. How do you all keep, we all keep in our mind? There's a simplest approach called as 6-step approach. If you apply this formula and look into the ABG, then you will never forget how to interpret an ABG. So these are the 6 steps which you have to keep in your mind. The first is, like what I said in my ECG class, the 5 steps. The ABG is for 6 steps. First is acidemic or alkalemic, whether it is primary disturbance in respiratory system or metabolic system. Third is, if it is respiratory, you have to look into whether it is acute or chronic. If it is metabolic, you have to look in for anion gap. And then fifth one is, if there is metabolic disturbance, then you have to look into what is the anion gap acidosis. And lastly, if there is to assess normal respiratory system, respiratory compensation for a metabolic disturbance. So these are the 6 steps. Even if you forget the last 2 steps, that is 5th and 6th, if you understand the 1st to 4th, that is very good, and you're going to manage the patient very well. So this is what we all have to keep in our mind. Now, first is step 1. All of you have already answered, so it will become very easy for me. Acidemia means, so never mention it as an acidosis or alkalosis until your final diagnosis. It is always you have to mention it as acidemic or alkalemic. Acidemic is less than, pH is less than 7.35, and alkalemic is more than 7.45. So this is the basic one. So step 1 is the easiest one. You can say whether this patient is in acidemic or alkalemic. Now step 2, look into whether the primary disturbance is with the respiratory system or metabolic system. So as I mentioned, what is the thing which is required to tell for respiratory system? What is the main primary abnormality in the respiratory system? Very good, PSUO2. What is the thing which is required for metabolic? Very good, bicarbonate. So this is what is the step 2. So we have to go to step 3. So if it is metabolic disorder will alter, then we have to look into bicarbonate. And bicarbonate levels you have to look into, if it is less than 22, it is metabolic acidosis, then we have to go for step 4. So you look into the problem, that is carbon dioxide level, you go for step 3. If it is the problem is with the bicarbonate level, you have to go to step 4. That is the simplest thing what you have to look in for. When do you say it is metabolic alkalosis? The bicarbonate level should be more than 26. That is what is the primary abnormality which is present. Now, there are 2 parts when you're looking into the respiratory system. That is the step 3, whether this patient is because of acute illness or chronic illness. So a patient is coming with tachypnea sudden onset. So we all know what it is. It is because of acute illness. When a patient is a long-standing COPD coming to your hospital, when you look into the pH is low, but is looking normal. That means that it is the simplest way to tell that it is a chronic problem. So this is how the simplest way to tell it is because of an acute illness or a chronic illness. So this is the formula which you have to utilize, whether it is acute, whether it is for respiratory acidosis or respiratory alkalosis. I will give you the formula in the other way. Okay. So respiratory acidosis, when we are applying for an example, you will understand better. Okay. You just note down whenever the pH is low and you have to calculate 0.008 into PaCO2 minus 40. 35 to 45 is a normal PaCO2, but as a standard, we can take it as 40. And if it is chronic, it is 0.003 into PaCO2 minus 40. So this is what is a formula you have to apply for to know whether this patient is having acute illness or chronic illness. Same way for the alkalosis also. It is the same. The only thing is how the delta pH is going up. Okay. So we'll apply few examples and see. Now first we'll look into some of the examples which is causing respiratory acidosis. The commonest problem is, as I mentioned you, if a patient or somebody is not taking proper breaths, that is the respiratory rate of less than 10, is having very low respiration. That means that the carbon dioxide is building up. When the carbon dioxide is building up, naturally the pH will come down and the patient is going for respiratory acidosis. Any other causes, it can be because central nervous system or pulmonary system or musculoskeletal disorders. So any of these things like sedative, use of sedatives, what it will cause? The patient cannot breathe. Any CNS disorders, patient cannot breathe. Patient with asthma or chronic lung disease also, he cannot have normalized breathing pattern. Guillain-Barré syndrome or myasthenia gravis is also some of the examples which can cause respiratory acidosis. Now, what are the causes of respiratory alkalosis? That means that the carbon dioxide is washed out. So when a patient is coming with increased respiratory rate, when he takes more and more respiratory rate, what happens is he's throwing out all his carbon dioxide outside. That is the first example is here, hyperventilation. Especially, we all know if you are facing some kind of an anxiety illness, this is what is going to happen. And whenever if somebody wants to hit some person, he will immediately try to have frightened or an anxiety like thing, which makes his carbon dioxide low and suddenly he will faint. That is what is a classical example. Any CNS events, hemorrhage is the one which the central nervous system, hemorrhage is the one which causes respiratory alkalosis because of tachypnea, and drugs like salicylates and anxiety, which I've already mentioned. So this is what we have to understand in step 3. That is, you have identified the abnormality as carbon dioxide. So you're going in for respiratory system. Now, carbon dioxide is not involved, but bicarbonate is involved. Then you're going into metabolic acidosis. Now, what is anion? What do you mean by anion? I'll take all the questions at the end. What is anion gap? It is the difference between positive and negative ions. That is the difference which you get the anion. Okay, we'll see what are the major anions and cations. So in the anion gap, that is sodium, that is what is present in excess in the extracellular fluid. When you take an ABG and C, you will get a sodium value, you'll get a chloride value, and you'll get a bicarb value. So sodium is a positive ion and chloride and bicarb is the negative ions. So you calculate between the positive and the negative ions. That is what you will get the report. The normal anion gap is 12 plus or minus 2. That is what is being calculated as. So positive ion minus negative ion. Sodium is usually the highest one, usually between 135 to 145. Chloride is between 98 to 105 and bicarb is between 22 to 26. So when you subtract the positive and the negative anions, you will get it as 12 plus or minus. This is the normal ion gap which is present in the body. Now, whenever the anion gap is more than 12, then it is called as high anion gap metabolic acidosis. Whenever the anion gap is less than 12, then it is called as non-anion gap metabolic acidosis. So these are the two things which we have to keep in our mind. Now, what are the causes of anion gap metabolic acidosis? This has been taught right from our first year MBBS classes, so I'll not go into it. So there is a decrease in the bicarbonate, but increase in the anion gap. That is what it means. Now, what are the causes of non-anion gap metabolic acidosis? This particular slide is very important because this is what keeps confusing us. The non-anion gap metabolic acidosis is commonly seen in diarrhea, that is GI loss of bicarbonate. Whenever there is a loss from the gastrointestinal tract, especially in diarrhea, that causes non-anion gap metabolic acidosis or renal tubular acidosis. Again, a typical example where the bicarbonates are being kept back and hydrogen ion is excreted. So this is a cause of non-anion gap metabolic acidosis. Now, I hope you all have understood. So look into the acidemia or alkalemia, look into whether it is a respiratory system or metabolic system, then look into whether it is acute respiratory illness or chronic respiratory illness. And if it is metabolic illness, you have to look into whether it is because of high anion gap or non-anion gap metabolic acidosis. So these are the four important steps when you are looking into the ABG, you have to keep in your mind. Now, the step 5 and step 6, if you don't remember also, no worries. These are important, especially in the critical care units where you have to adjust the ventilatory management. But for a basic science, sometimes they may ask you in the exams, you have to know this. So what are you looking into in the step 5? Is there another metabolic disturbance coexisting with an anion gap acidosis? That is what you're going to see. So that is what is in step 5. So corrected bicarbonate is equal to bicarb plus anion gap minus 12. That is what you're going to see. So you have to look into what is the corrected bicarbonate. That is the normal bicarbonate value is 22 plus anion gap minus 12. That is the normal anion gap is 12. Usually in high anion gap, what happens is you can see more than 12. So this is what you have to check it for, if there is a correction of the bicarbonate or not. So here you can see here, if the corrected bicarbonate is between 22 to 26, that is, it means that it is only purely an gap metabolic acidosis. If it is more than 26, then there is an additional metabolic alkalosis also is present. And if it is less than 22, that means that anion gap metabolic acidosis is associated with another non-anion gap metabolic acidosis. So these are all complex things, but just for completion's sake, you have to understand and keep it in your mind. Only the first 4 steps are very, very important. Like to give you an example, the bicarbonate level is 10 and the anion gap is 26. So you can see here the corrected bicarbonate is equal to 10. That is what is the given level plus 26 minus 12 is equal to 24. So there is no additional disturbances which is present. Now bicarbonate is 15, the given bicarbonate is 15, but the same anion gap is 26. Then the corrected bicarbonate is equal to 29. That means that this patient has a coexisting metabolic alkalosis. So this is what it means. This is how you can apply the formula into your day-to-day practice or keep thinking it and do it so you will understand better. Now, I hope step 5 you've understood. That is a bicarbonate component. That is whether you want to see whether there is a coexisting either metabolic alkalosis or there is a coexisting non-anion gap metabolic acidosis. That is what you're going to see in step 5. Basically, in step 6, what you're going to see is the Winter's formula. Winter's formula. That is here, you're looking into assessing whether the respiratory compensation has happened with the metabolic acidosis or not. So you're going to look into whether there is a normal respiratory compensation for a metabolic acidosis or not. This is what you're going to watch out for. So applying Winter's formula, that is expected PaCO2 is equal to 1.5 times the bicarb plus 8 plus or minus 2. That is what is Winter's formula. All these formulas are been there, and there are ready apps today for the ABG, and most of them use this one. But still, for to keep us updated, and if you don't have those kinds of gadgets, it's important that you mention in your case sheet what type of an acidosis, what type of problem is the patient is having. So this is what is important. If bicarbonate is 10 and PaCO2 should be between 21 to 25. If the PaCO2 is less than 21, that means that there is an additional respiratory alkalosis. Or if the carbon dioxide is more than 25, that means that patient can have an additional respiratory acidosis. That is what Winter's formula application is for. So these are the things which we have to keep in mind when you're watching out for the respiratory or metabolic acidosis. Now, this is how ABG is being taught and is being looked after. So what do you look into? Assessing the normal respiratory compensation for a metabolic disturbance, or if metabolic alkalosis is present, then Winter's formula is not applicable. This part you have to keep in mind. Only when the patient is having metabolic acidosis, then only you have to look into the respiratory compensation. Otherwise, you should not look in for. So this is what is the disorder and what your expected compensation. In case of metabolic acidosis or acute respiratory acidosis or chronic respiratory acidosis or metabolic alkalosis or acute respiratory alkalosis or chronic respiratory alkalosis. This is what on the right hand side you can see the expected compensation which has to happen. This whole slide tells you what is the disorder and what is the expected compensation. So if you read this whole slide thoroughly, then nothing is impossible for you to maintain the ABG levels and treat the cause accordingly. Now, we have seen enough about all these things. Over the next 10 to 12 minutes, we'll practice. Because you've all seen what it is, now we have to know whether we can learn ABG and analyze the ABG and interpret or not. Now, a patient of 5-month-old baby with bronchiolitis history has come to the hospital and the pediatrician has asked for an ABG. ABG is showing like this: a pH of 7.24, PaCO2 of 60, bicarb is like this, and then there is a base excess and the saturation is 85% with a FiO2 of 70%. Very, very important is whenever you're mentioning in the ABG, please make a note how much of oxygen you're giving for the patient. Otherwise, the figures may alter and you may be thinking why this patient's ABG is like this. Then you will not be able to read it properly. Okay. So what is your diagnosis? Acidemic. Very good. So step 1 is acidemia. So what type of a compensation primary disturbance it is? Respiratory. Very good. So it is respiratory system which is involved. Now what we have to look in for, whether it is because of acute illness or chronic illness. So we'll apply the formula and see whether it is acute or chronic. So expected pH is 7.4 is equal to 0.008 into 60. That is what is the carbon dioxide level which is on the ABG minus 40. So 0.16. That is what is the value you have got. See, normal pH is 7.4 minus 0.16 is equal to 7.24. So the given pH and the value which we have got is correct. That means that this patient is having acute respiratory acidosis. This is the complete diagnosis you have to give in for acute respiratory acidosis. Now, if we calculate for chronic, say 0.003 into 60 minus 40 is 20, you will get only 0.06. So 7.4 minus 0.06 is equal to 7.34. So the given pH is 7.24, whereas if you put as a chronic formula and see it is 7.34, it is not matching. So this patient doesn't have a chronic illness. This patient has an acute illness. So that is the reason why you are telling it as acute respiratory acidosis. Now, this particular patient, a 3-year-old boy, has come to your hospital with diarrhea and decreased urine output. Lethargy is there. Sodium is 135 and chloride is 115. The pH is 7.10. Bicarbonate is 8. Now, with the oxygen is not requiring any kind of an oxygen. So what is the primary disturbance here? Acidemic or alkalemic? Yeah, very good. So the disturbance here is, what is the primary disturbance? Metabolic disturbance. Very good. Now when it is metabolic illness, we have to go for step 4, not to step 3. Step 3 is respiratory, step 4 is metabolic. So what happens? Metabolic means, what do we have to calculate? We have to calculate the anion gap. So the anion gap is, the sodium levels is 135 and the chloride is 115 plus bicarbonate is 8. So 135 minus 123 is equal to 12. So there is nothing here. It is normal anion gap or non-anion gap metabolic acidosis. What is the cause of this non-anion gap metabolic acidosis? If you remember the causes of non-anion gap metabolic acidosis, you can see the major issue is diarrhea. So diarrhea is there. So this particular patient, you need not treat with bicarbonate or anything. Just give them fluids. It will adjust itself and the patient will become normal. So this is how we have to look in for. Now, here is a 50-year-old patient, had a cardiac arrest. He has been taken ABG. The pH is 7.1. Carbon dioxide is 60. Bicarb is 10 with sodium of 142 and chloride of 108. Now again, what is the primary abnormality? Acidosis, very good. Respiratory or this one metabolic? The primary disturbance is both metabolic as well as respiratory system, because it is a mixed. Very good. Both respiratory and metabolic is involved. So what is the anion gap here? The anion gap is sodium minus chloride plus bicarbonate, that is 142 minus 108 plus 10, that is 24. That means that this patient is having high anion gap metabolic acidosis, and there is a compensation or not. You can and see whether there is a compensation or not. Yes, there is a compensation which has happened. What is the corrected bicarbonate? The corrected bicarbonate is equal to 10 plus 24 minus 12, that is equal to 22. And also, what is the expected carbon dioxide? So the PaCO2 into 1.5 times the bicarb plus 8 plus or minus 2. You apply the formula, the Winter's formula, and see. So you can see 21 to 25. So what is your final diagnosis now? So it is a mixed metabolic and respiratory acidosis. So most of them have answered correctly. Good one. So case 4, another 2 cases, and we'll take your questions. A patient, 4-year-old girl, has come to a hospital with lethargy, irritability, and patient is also having jaundice. ABG was taken. Oxygen levels was FiO2 was 33%, the pH is 7.52, carbon dioxide is 26, bicarb is 22. So what is the primary abnormality here? Acidemia or alkalemia? Respiratory alkalosis. So go by step, it is alkalemic, and the primary abnormality which is involved is respiratory system because the carbon dioxide is low. So the pH is high, carbon dioxide and bicarb is low. That is what you're seeing. So whether it is acute or chronic, we'll apply the formula and see pH is equal to 0.008 into 26 minus 40. So it is equal to 0.11. So 7.4 plus 0.11 is equal to 7.51. That means that the given pH and the calculated pH is almost nearing to normal. That means that this patient has acute respiratory alkalosis. Now, if we apply the chronic formula and see 0.003 into 26 minus 40 is 14. So 14 into 3 is equal to 52. So 0.05. So 7.4 plus 0.05 is equal to 7.45. So that means that it is not matching. It is acute respiratory alkalosis only. So this is how, when you apply the formula and see, you can understand and mention it. So a patient with near fatal asthma is on ventilator, and the pH, when the ABG is taken, the pH is 7.14, carbon dioxide is 70, and bicarb is 26. And this is what is the ventilatory settings. Now, what is the basic abnormality? Acidemia or alkalemia? Acute acidosis. Very good. Acidemia. So primary abnormality is respiratory or metabolic? It is respiratory system. Whether it is acute or chronic, we'll apply the formula and see 0.008 into 70 minus 40, that is 0.24. So 7.4 minus 0.24 is equal to 7.16. So it is nearing, sorry for the mistake here. It is 7.16. So the given pH and the calculated pH is nearing to normal. So that means that the patient is having acute respiratory acidosis. Now, a little bit of adjustment here. What are you going to do? The treatment? Increase the respiratory rate, increase the tidal volume, give nebulization or bronchodilators, or the B, reduce the respiratory rate, decrease the tidal volume, nebulization and bronchodilators. A or B? Very good, B. So the right treatment is reduce the respiratory rate, reduce the tidal volume, increase the expiratory time. That is what you are supposed to do, so that it will be very helpful for the patient and reverse the patients, and the pH will become almost normalization. The last one, a 50-year-old gentleman with pain abdomen, increased urine output, lethargy, sodium is 135, chloride is 110, blood glucose levels is 600, and the ABG shows like this: 7.1 of pH, bicarb is 20, bicarb is 12, and carbon dioxide is 20. So the important point here is you have to calculate the corrected sodium. That is very, very important, because whenever the glucose levels is more than 250 milligrams per deciliter, the sodium will be changing itself, because for the sodium metabolism and the sodium levels to be kept normalization, glucose is also important. So the corrected sodium will be 144. So 136, so the corrected sodium is sodium plus 600 minus 100 divided by 100 into 1.6. This formula also you can keep in your mind. If this is not very important, but if you get something about sodium metabolism and somebody is asking about sodium metabolism, then you can write this particular answer for your question. So acidosis, very good. Acidemia is the first one. So where is the abnormality? Metabolic, very good. So you have to calculate for the anion gap. So 144 minus 110 plus 12, that is 22. So there is increased ion gap. So that is equal to high anion gap. One of the causes is diabetic ketoacidosis. Very good. Diabetic ketoacidosis with metabolic acidosis. So here we are not treating with bicarbonate. Please keep in your mind, if you give bicarbonate for this PA patients, there will be paradoxical acidosis and patient will die because of acidosis only. That is very important cause of reversible cardiac arrest. So treat the cause, give them fluids, give them insulin. Potassium should be corrected because low potassium is also very, very dangerous. And other whatever treatment protocol is there as per your hospital, treat them. So what is my carry home message? The carry home message is the approach for acid-base disorders should always look into emphasizing the search for the cause and treat the cause. Don't treat the pH. Don't bring back the pH to normalcy. If you treat the cause, the pH itself will come back to normal. ABG is always like an ocean. Whenever I teach somebody or when I see an ABG, I always keep thinking, what is this? So when you go in a stepwise manner, you will never forget it. So this is what you all have to enjoy only at the shore because we can't go into the sea. So our motto is always only one. Each one should teach one to save more lives. So in the same way, everybody, those who have attended the class, you have to learn by only teaching to others. When you see an ABG, try to get a sister, try to get another fellow and start teaching him, okay, this is what is abnormality. You will never forget. ECG and ABG is main important things in your life. Thank you all. Be safe by wearing proper PPE. Any questions? I'm ready to take.
So thank you very much for that excellent presentation. I think for the postgraduates and for students, I think the best way is to only practice. You can hear any amount of lectures, but unless you put that into practice, you will never become perfect. So as he said, next time you see an ABG, take it as a teaching for yourself and for others. That's the best way to learn.
Okay, we will upload the PowerPoint. It will be on the ANBAI website. You can download it.
So you can exit the screen. Srinath, sir.
Solung, Anthony.
You may exit the screen, sir.
Okay, Anthony. Yeah. How to join ANBAI? You have to go into the ANBAI website, anbai.org, and then you can see the membership portal there, and you can join.
If there are no more questions, I think we'll conclude the session. Thank you.
Thank you, Dr. Dilip, for this moderation.
Thank you.
Thank you. Thank you, Anthony.
Thank you, sir. Thank you, Dilip, sir. Thank you, Srinath, sir.